In this section, I'm going to give you a little introduction, those factors that influencing the ST segment. Some criteria, how can you differentiate the ischemic changes. What is a secondary? Secondary usually caused by a change in the ventricular activation. If you do have an abnormal activation, the repolarization is altered as well, and this will influence the STT segment, such as left bundle branch block. The STT changes in the opposite direction compared to the terminal portion of the QRS. If we do have positive R wave, we do have a negative inverted STT. Why, if we do have a QS or deep S wave, the opposite would the ST elevation with a positive T wave. Hemiblocks can alter the STT segment as well. We do have some non-specific ventricular conduction abnormalities where we do see some STT changes. WPW, pre-excitation syndrome. Again, because a certain part of the ventricle activated through the muscle, this is why we do have the altered repolarization. Ventricular arrhythmias, because the impulse made by the ventricle and the ventricle activated through the muscle, we always have STT changes. The primary STT changes is independent from the ventricular activation and is partially or completely dependent on the ventricular repolarization. These can develop due to medication, Digitalis, quinidine, ion changes such we discussed in hypokalemia, ischemia, infarct, inflammation, neurological abnormalities such as a Subarachnoid hemorrhage. The differential diagnosis of the ST elevation. We do have several situations when the ST segment is altered. A very important one, the normal ST elevation. In normal ST elevation can be seen especially when we compare the ST elevation to the PQ or PR segment. In the age group for 16 to 58, there is 1 to 3 millimeters ST elevation occurring is about 91% of the cases, without any underlying ischemic disease. In the frontal leads, especially in the precordial V2. It is less common with increasing age. However, in women, the frequency is less, but it's independent from the age. Not identical to the normal variant. That's be different one we are going to discuss in the next session. The ST segment is concave, and the magnitude of the elevation correlates with the size of the S wave. As you see here, deep S, and when S wave is deepening, the ST elevation increases. The normal variant of the ST elevation, this occurs relatively is a huge amount of young healthy individuals, especially in blacks. In the precordial leads, the ST elevation can be as much as 1 to 4 millimeters. The most pronounced in V4, where a notch can be seen. That can be the J point. The ST segment is concave. The T wave is usually tall and not inverted. This is the upright position. The PR segment depression may be observed as well. Early repolarization. It is the common and usual benign ECG finding. Experimental evidence suggests that it is a arrhythmogenic potential. Signs on ECG, J-point elevation, the last portion of the R wave is nudged, the ST segment is concave from above, quick QRS progression, anti-clockwise rotation, bradycardia is very frequent one. In this graph, we are going to summarize the typical shape of the different types of ST elevation, such as the normal ST segment elevation, where we do have a normal R progression, and depending on the depth of the S wave, this is how the ST segment is elevated. In early repolarization pattern, as you see here, we do have mostly in V4 when we do have the ST elevation, we do see a little J point, a little notch at the end. The T wave is positive, and the normal variant when we do see the ST elevation with the J point. However, as you see here, the T wave is inverted, is negative. ST elevation can be seen in a lot of cases, such as acute pericarditis, pulmonary embolism, hypothermia, hypertrophic cardiomyopathy, hyperkalemia, subarachnoid hemorrhage, Brugada syndrome, cardiac aneurysm, left ventricular hypertrophy, ventricular rhythm, myocardial MI, and so on and so on. We will discuss the most common one, and what we already discussed, such as the hypothermia and hyperkalemia. We want to refer to the pericarditis. This is an inflammatory disease of the pericardium or the muscle, when usually occurs after viral infection, is accompanied by the chest pain, usually occurs retrosternally and pleurally. The pain is more intensive in a supine position. Leaning forward when seated alleviates the symptoms. It is accompanied by the tachycardia and dyspnea. Pericardial friction rub and pericardial fluid accumulation may be present as well. Sign on the ECG, the ST elevation in multiple independent leads. So those ST elevation does not depend on the coronary supplied structure. Looking at this graph, that's rhythmic, that's tachycardic, that's sinus one. PR, P is normal, PR is normal. ST elevation can be seen in 1, 2, 3, AVF, and in the lead of V5 and V6. So we do see in the lateral and an inferior as well. Reciprocal changes, ST depression and PR elevation appear in V1 and mostly in AVR. This tracing shows the hypothermia induced Osborn-wave. You can see here in V1, V2, V3 at the J point and the ST elevation. Brugada syndrome. Brugada syndrome occurs due to the mutation of the myocyte sodium ion channeling gene, the CN5A. More than 60 different mutations have been described so far. At least 50% of these are spontaneous mutations. Follows autosomal dominant inheritance pattern. ECG changes may be transient. Manifestation can be triggered or inhibited by several factors, such as fever, ischemia, drugs, hypokalemia, hypothermia, and using of the cardioversion and defibrillation again can cause typical sign of these Brugada syndromes. Diagnosis of Brugada syndromes. The following clinical symptoms should accompany the ECG sign. So not enough to see an ECG sign, but you have to have some clinical data as well. Occasional ventricular fibrillation or polymorphic ventricular tachycardia in the past. Sudden cardiac death in the family history that before age of 45. Ventricular fibrillation can be induced by electric stimulation, syncope for example, and agonizing breathing at night, pattern at night. The ECG sign is a very typical one when we do have a type 1 curved ST elevation with negative T wave. This is the only potential diagnostic sign on ECG. This ST elevation is more than 2 mm in V1 and is more than 1 mm in V2, V3. As you see here in this ECG in V1, V2, we do have the typical Brugada ST elevation. Subarachnoid hemorrhage. Here we do have ST elevation all the way. Lead number 1, lead number 2, lead number AVL, AVF, a little bit in lead number 3. We do have in V4, V5, V6, so a huge area presenting ST elevation. For sure, we are not going to diagnose subarachnoid hemorrhage based on the ECG, but we have to know that, yeah, in this case, we do have some atypical ST elevation on the ECG tracing as well. Types of abnormal ST elevation. This table is summarizing the different ST elevations, such as happening in left ventricular hypertrophy, As you do see, the secondary changes exactly opposite the major deflection of the QRS complex. Left bundle branch block is very similar. Acute pericarditis, always we do have ST elevation, it's almost the all lead. Pseudo-infarction pattern in hyperkalemia, that is similar to the Brugada, except in some lead we do have a very tall T wave. In acute anteroseptal MI and in anteroseptal MI plus a right bundle branch block, and the Brugada syndrome is listed here. Clinical entities accompanied by depression, so ventricular hypertrophy such as a strain, digitalis, hypokalemia, hypomagnesemia, acute neurological abnormalities induced by high cardiac frequencies. Digitalis effect on ECG. Digitalis is a sodium-potassium channel blocker, and because we are blocking this pump, the intracellular sodium will increase. This meaning that the resting membrane potential is getting closer to a threshold. So the chance that ectopic impulse formation increases is high. This is why ventricular premature beat formation, bigeminy, trigeminy, supraventricular tachycardia can develop. The cell does not like when the intracellular sodium concentration increases. This is why the sodium-potassium antiporter activation happening, and the intracellular calcium exchange by intracellular sodium concentration exchanged by the calcium, and the increased intracellular calcium will increase the contractility, and it will increase the pulse pressure. That causes vagotonia. The nervus vagus is activated. That will affect the heart as bradycardia, the sinus node, the AV blocks that can be first degree, second, and third degree, and escape rhythm, junctional, and ventricular can develop. Slurred scoop resembling either the reverse stick or the honey stick. ST depression can be seen. Digitalis effect summarized on this graph. This is arrhythmic, no P wave, atrial fibrillation, and then on the left ventricle leads we do have this scooped ST segment, and that can be the sign of digitalis. As you see here, lead number 2, there's a scooped ST segment and the typical signs. What will happen with the T waves? The T wave is altered when we have ischemia and myocardial MI, pericarditis, myocarditis, mitral prolapse, subarachnoid hemorrhage altering the T wave, and myocardial contusion, digitalis, ventricular hypertrophy, such as in the case of the strain.